Your heart is pounding. Your chest is tight. You cannot get a full breath. Your hands are tingling and your vision has gone slightly wrong around the edges. You are certain something is seriously wrong with you, and you do not know whether to call emergency services or sit down and breathe through it. This is the moment that sends millions of people to emergency departments every year, and it is one of the most genuinely difficult clinical distinctions in medicine, because a panic attack and a heart attack can feel, from the inside, almost identical. Almost. Both cause chest pain. Both cause a racing heart. Both cause shortness of breath, dizziness, tingling in the extremities, and a profound sense that something catastrophic is happening. Both peak in intensity within minutes. Both produce a terror that feels physiologically justified because the body's alarm system is firing at maximum volume. The overlap is not coincidence. It is biology. During a panic attack, the sympathetic nervous system, the fight-or-flight system, activates fully. Adrenaline floods the bloodstream. Heart rate surges. Blood vessels constrict. The chest wall muscles tighten. Breathing becomes shallow and rapid, which drops CO2 levels in the blood, causing tingling in the hands, feet, and face, dizziness, and a sense of unreality. The body is producing a genuine physiological emergency response to a perceived threat, and the physical experience of that response is, neurologically and chemically, almost indistinguishable from the physical experience of cardiac distress, which is why telling them apart by symptom alone is so difficult, and why the one distinguishing feature, when you know what it is, matters so much. The one symptom that separates them is this: what happens when you press on your chest? With a panic attack, the chest discomfort is diffuse, variable, and often changes in character. It may move. It may shift when you change position. It frequently worsens with hyperventilation, the rapid shallow breathing that panic produces, and eases, even slightly, when breathing slows. With a heart attack, the chest pain or pressure does not respond to any of these things. It does not change when you press on it. It does not ease when you take a slow breath. It does not shift when you lean forward or lie back. It is fixed. It is consistent. It is indifferent to everything you do, because it is not coming from the chest wall or the muscles or the nervous system. It is coming from the heart muscle itself, which is not receiving blood, and which has no mechanism to ease its distress based on posture or breathing or conscious calming. Pressing firmly on the sternum or the chest wall during cardiac pain produces no change. Pressing on the chest during musculoskeletal or anxiety-related chest pain almost always reproduces or alters it. This single test, reproducibility on palpation, is one of the first things an emergency physician does when assessing chest pain. It takes 5 seconds, and the answer changes everything. But there is a second layer to this distinction that matters equally, and that is the sweat. Both panic attacks and heart attacks produce sweating, but the sweat is different in a way that is clinically significant and physically recognizable. A panic attack produces a warm, anxious sweat, the same sweat that comes with embarrassment or physical exertion. The body is hot, the skin is flushed. The sweat is the result of sympathetic activation driving heat to the surface. A heart attack produces cold, clammy diaphoresis. The skin is pale or gray. The sweat is profuse and appears without the body being hot, because it is produced not by heat, but by the cardiovascular system failing to maintain adequate output. The body is shunting blood away from the skin to protect the vital organs. The surface becomes cold, damp, and pale simultaneously. The person often describes it as the worst they have ever felt in their life, not just frightened, but a deeper, more physical wrongness that is difficult to articulate. If the chest pain is accompanied by cold, clammy skin, and the person looks pale or gray, that is a cardiac presentation until proven otherwise. The character of the sweat is not a subtle distinction. It is a visible, physical difference that other people in the room can see. The timing pattern also diverges in a way that is important to understand. A panic attack peaks within 10 minutes. This is physiological. The sympathetic nervous system cannot maintain maximum activation indefinitely. Adrenaline clears, CO2 levels normalize as breathing slows. The peak of terror and physical sensation is real and extreme, but it has a ceiling and it has a descent. By 20 to 30 minutes, the acute phase has typically passed, even if the exhaustion and residual anxiety that follows lasts for hours. A heart attack does not peak and descend. The pain or pressure is persistent. It may fluctuate slightly, but it does not resolve without intervention. A chest pain that came on 25 minutes ago and is showing no signs of easing. That is not responding to position change or breathing. That is accompanied by pain in the jaw, arm, or between the shoulder blades. That is not a panic attack that has gone on longer than usual. That is a cardiac event. Time to intervention in a heart attack is the single most important determinant of how much heart muscle is lost. Every 30 minutes of delay doubles the area of myocardial damage. This is why the instinct to sit quietly and wait to see if it passes, which is appropriate for panic, is the worst possible response to a cardiac event. There is one more distinction that most people are not told, and it concerns who gets misdiagnosed most often. Women presenting with heart attacks are significantly more likely than men to be assessed as having anxiety or a panic disorder. This is partly because women's cardiac presentations are more frequently atypical, less classic crushing chest pain, more nausea, jaw pain, fatigue, and shortness of breath, and partly because women's cardiac symptoms have historically been underweighted in clinical settings. A 2018 study in Circulation found that women under 55 are twice as likely as men to be misdiagnosed when presenting with a heart attack in the emergency department. The consequence of that misdiagnosis in a cardiac event is measured in heart muscle, which is why any woman presenting with chest discomfort, shortness of breath, jaw or arm pain, cold sweat, and nausea, regardless of whether it also feels like anxiety, should insist on an ECG and cardiac enzyme tests before accepting a diagnosis of panic disorder. An ECG takes minutes. Troponin, the blood test that detects cardiac muscle damage, provides a definitive answer within hours. These tests exist precisely for this ambiguity. They should always be used when the presentation is unclear. So how do you use this in the moment? Press on your chest. If the pressure reproduces, shifts, or changes the pain, that points toward panic or musculoskeletal origin. If pressing on the chest makes no difference to what you feel inside, do not wait. Check the sweat. If you are warm, flushed, and the sweat feels like exertion, panic is more likely. If you are cold, clammy, and pale, call emergency services now. Check the timeline. If it has been more than 20 minutes and the intensity is not declining, treat it as cardiac until a physician with an ECG tells you otherwise. Check for radiation. Pain that moves into the jaw, the left arm, the neck, or through to the back between the shoulder blades is referred cardiac pain. Panic attacks do not refer pain to the jaw. If you feel it there, do not wait. Panic attacks are real. The physical suffering during one is not performance or weakness. It is a genuine physiological event that the body experiences as life-threatening. People who have them deserve to understand what is happening and why, not to be dismissed. But a panic attack has never damaged the heart muscle. A missed heart attack has. When the chest tightens and the breath shortens and the alarm fires, know the difference. Press on your chest. Look at your skin. Note the time. Check for the jaw. The symptoms that feel identical have one place where they diverge. Now you know where to look.